At least I have the privilege of being somewhat in PE. Haven't been there in a while, but the memories that I have of PE is a very awesome holiday destination. So I don't know how you get much work done there. So let's talk today a little bit about insulin in the difficult to treat type 2 diabetic patients. So whatever I speak about today in terms of insulin and how it works is referring specifically to the type 2 diabetic, which forms at least 80 to 90% of the patient population that we deal with in South Africa. So what is important to understand is how diabetes works. So if you understand the pathophysiology, and if you understand the medications that are available, then you can understand the specific patient that has a specific problem and what treatment would work for them, right? And the topic was basically is this the end of the road? But, and how do you treat this difficult to manage type 2 diabetic? Now, it may be, as you'll see from the slide, the end of the road for the beta cell, because when the patient is diagnosed with diabetes, it is said that the patient loses at least 50% of their beta function. And this decline in beta function perhaps started up to 10 or 12 years before they actually got the diagnosis of diabetes. So they may have been having pre-diabetes and having some underlying pathology related to diabetes much longer than when they first diagnosed with diabetes. And despite therapy, the beta cell still declines at a rate of 4% per annum. And this we know is true for type 2 diabetics. We don't yet have any therapy available that can slow down the progression of this beta cell failure. And as you all are aware, beta cells are the cells in the pancreas that are responsible for releasing insulin. So when beta cell function declines, the patient, of course, then needs to go on to insulin. What you can also see on the slide is that if 0.0 is the time of diagnosis, most type 2 diabetics get to use about insulin 8 to 10 years after starting the initial therapy, which is, of course, metformin and then a sulfonylurea. And now we have many other therapies that can fit in between while the beta cell is functioning until we get to the stage where beta cell doesn't work at all and we have to start insulin. So looking at the pathogenesis of type 2 diabetes, let's look at firstly the insulin action, right? In a person who is not diabetic, and I don't like to say normal because diabetics are not necessarily abnormal. They just have a genetic defect where the beta cells don't function well. And as they progress to impaired glucose tolerance, diabetes, and then a full progression to type 2 diabetes, insulin action declines. And as insulin action declines, you find patients then can develop, as in certain patients, you can get insulin resistance. And then initially, as the insulin action starts declining, the body tries to compensate for the increase in glycemic values, blood levels, by hyper-secreting insulin. So the beta cells are then functioning at above normal rate, which then causes beta cell failure eventually. And then you can see that the beta cell hyperfunctions and then the function starts decreasing, right? And this is when we start seeing the insulin deficiency. Glucose, of course, then when a patient is not diabetic, the glucose, we call it euglycemia because glucose values are fine. But as insulin action starts coming down, glucose starts increasing. So the green squares, dotted squared line shows how glucose values start increasing as insulin action starts decreasing. Eventually, the patient develops hyperglycemia, and that is when you find HbA1c values start going above 7%. And then once the HbA1c approaches 9%, that is when usually at a point where the pink line and the green line cross is when you usually diagnose diabetes. And at the point where the green line is very far from the pink line, you find the insulin action is down, glucose values are very high, and that is where we start insulin therapy in the diabetic patient. So we start off with a bit of insulin resistance, then there's a mixed picture, and then we develop beta cell dysfunction. What is important to note that all type 2 diabetics eventually will get to insulin. In the recent past, there were studies that were done that looked at different subtypes of type 2 diabetes, where we found that certain patients who started on metformin continued with metformin for the duration of their lifespan without any issues. Some patients quickly go onto insulin, and some patients get a mixed picture where they do kind of well on the oral therapy, and then after a couple of years, they have to go onto insulin due to beta cell dysfunction. And some patients are also at an increased risk of developing complications of diabetes. So now we talk of the 5 different subtypes of diabetes which can occur. However, for this talk, I'm going to talk about patients who seem to be very difficult to control. And a diabetic patient who is difficult to control basically means we are struggling to get their glucose values down. And if that is the case, most often they are insulin resistant, and therefore we will have to use insulin therapy, right? So this is the point where the patient needs insulin therapy, where the insulin is completely deficient, the beta cells are not producing insulin anymore. So what are the effects of prolonged hypoglycemia? What is the hype about? I have patients who come in and they say, "Doc, my glucose runs at 15 every day and I'm fine. I do everything I want to. I enjoy my life." But what they don't realize is that happiness or that good health is probably temporary, because with time, you do develop chronic complications of diabetes. And we all know what these are. You basically divide the chronic complications into macrovascular complications and microvascular complications. Incidentally, glucose control has a good impact on microvascular complications like nephropathy, neuropathy, and retinopathy. However, macrovascular complications need somewhat of a different approach to therapy, which I'm not going to go into too much today, but that's where we're looking at using the newer drugs like the SGLT2 inhibitors and the GLP-1 receptor agonists that seem to have a great impact on a stroke prevention and myocardial infarction, etc. Right? So when it comes to good glycemic control, what kind of an impact are you making in the patient? Right? Now, this study, the UK-PDS study, which was done a very long time ago, like in the 1980s, we're still using information from the study to see what impact glucose control by looking at reduction in HbA1c values has on complications in diabetes. And what we've learned from the UK-PDS study is that even a 1% reduction in HbA1c can result in 21% less deaths from diabetes, 14% less heart attacks, 37% less microvascular complications, and up to 43% less peripheral vascular disorders. So our job as clinicians, and I think sort of not in the clinicians that are looking after the complications like the cardiologist and the nephrologist and those doctors looking after the neuropathy, we have a responsibility as primary care physicians to make sure patients don't get these complications in the first place. And how we can do that is by reducing the HbA1c so we can prevent these complications. We are aware that, and if you look at the slide, it's quite evident that the reduction of 14% in macrovascular cardiovascular disease like heart disease, stroke, MIs is not very impactful by reducing HbA1c. And therefore, the newer drugs that we have, the GLP-1s, the SGLT2s, seem to have an impact there. When they did the UK-PDS study, as you're all aware, the type of drugs that we had available was basically the metformins, the sulfonylureas, and then insulin. So with the explosion of new drugs that we have at the moment, and the better formulations like MR, modified release formulations, and the extended release formulation drugs that have better pharmacokinetics, I suspect that these days we could actually get much better results in terms of preventing the microvascular complications with the drugs that we have available to us, and we have a much greater impact on preventing cardiovascular disease with the drugs that we have available. But still, it's important to note that even if you're using the older drugs and patients don't have access to the newer modern therapies, we can still make an impact by reducing HbA1c with the therapies that we do have available that are perhaps not as pricey and easier to get approved by the medical aids. So the physiologic insulin profile is quite important to understand, because if you understand this, then you know which type of drug fits in for the type of patient that you have. So how do you look at the slide and make it meaningful to you, right? So what is clear from the slide is that when you're not eating, you have a flat basal insulin production over 24 hours. When you do eat, you do need extra insulin to cover you for the calories that you're taking in for breakfast, for lunch, and for supper. And that's when you get the peak of insulin release whenever you do eat, right? So if you don't eat and you're not diabetic, you can easily downgrade your insulin by just having a basal profile, and you could be perfectly fine. Whenever you do eat, your body produces first the first phase insulin response, then the second phase insulin response, in order to keep your glycemic control between, in a non-diabetic patient, glucose never goes above 7.8 millimoles per liter, right? So your body tries to maintain homeostasis of glucose so that it doesn't cause damage to the arteries and cause macrovascular and microvascular complications. So if you look at this, you can understand that whatever therapies we have needs to match or mimic this type of physiologic insulin release. And if it matches this, then we're doing somewhat of a good job in preventing that patient from developing complications. So that's the objective, right? Now, we do have multiple insulin therapies available, right? And the insulin actions differ based on the type of insulins that we have available. So we have short-acting insulins like the Humalog Lispro and the Aspart. We've got pre-mixed insulins, which has different combinations of short and long-acting insulin in one insulin pen. And then we've got long-acting insulins, right? Now, what are the guidelines for effective management? Let's look at this. So this is where we're looking at our difficult to control type 2 diabetic patient. This is the patient where the patient has failed on maximum oral hyperglycemic agents, right? So if control is not attained with diet, because we know patients who you put on whatever therapy, the best that is on the market. But if the patient still decides to eat Cook Sisters and Malva pudding every day, the treatment's not going to help, right? So you need to make sure the patient follows a good glycemic diet. In other words, they need to understand the contribution of high glycemic index foods to glucose excursions. And what I tell my patient basically is that try to eat low GI meals, right? And try to make sure that you eat a protein with every carbohydrate that you eat. Therefore, you can lower the GI by that alone, right? And then you tend to eat less carbohydrates and you tend to have better satiety. So if the patients are on maximum oral hypoglycemic agents, and here we're now talking about then maximum doses of metformin, which is up to 2,000 milligrams per day, sulfonylurea is up to 120 milligrams per day on gliclazide MR, the 60 milligrams. Secondly, we then look at the HbA1c, right? Now, with the new ADA guidelines and the new guidelines that we have available with the newer therapies, we do find that we're not only looking at HbA1c, we're also looking at the patient's complication profile. So if the patient is at high risk of cardiovascular disease, specifically you're looking at heart failure, strokes, etc., then you would add an SGLT2 inhibitor, right? If the patient is at higher risk of atherosclerotic disease, then preferably choose a GLP-1 receptor agonist. If the patient doesn't have any of these complications and we're looking at pure glucose control, then when the patient's HbA1c goes to above 9%, we need to start insulin therapy. So please remember this. If the HbA1c is 9%, it is safe to start insulin. And how we do that is, initially we add a basal insulin, okay, to the existing oral hypoglycemic agent. So without basal insulin, most of the times you get the patient has a profile like this. So they get their post-breakfast, post-lunch, or post-dinner glycemic excursions. But as you can see from there, the average glucose is much higher. The fasting values range above 10%. Once you start a basal insulin, the type of profile you can get is just dropping the entire curve by at least 6 to 7 millimoles per liter. We can get the patient to far, far better control with fasting values that sit between 4 to 7 millimoles per liter, and postprandial values need to be under 10 millimoles per liter. So basal insulin alone can do this, okay? And it can reduce glucose toxicity. So what are the desirable properties of a good basal insulin? It needs to be neutral, so it doesn't burn at the injection site and it doesn't cause lipodystrophy. So the older insulins that we have, we used to see quite a lot of lipodystrophy. And this is just basic huge masses that patients develop at their injection sites on their tummy. It can occur also on their thighs or wherever else they're injecting. But with the newer analog insulins, we don't see this too much. We still can see it if patients still insist on injecting in the same site all the time. And what happens is, when you inject in those sites, patients usually don't feel anything. However, the absorption of insulin is not that good, right? So we want a basal insulin that's soluble at neutral pH. We need an insulin that is peakless and works for at least 24 hours, okay? By getting a peakless basal insulin, you get less morning hypoglycemia, and if you get less hypoglycemia, patients have less weight gain. So when I was asked to give this talk, then I was told that I need to maybe talk a little bit about how diabetic patients gain weight, because apparently the profile of patients that you see in PE, patients gain a lot of weight or patients are overweight, and you're trying to control that in order to prevent so much of weight gain, okay? Now, one of the ways you can do that is, number one, by preventing hypoglycemia. When patients get hypoglycemic, they're going to eat more, right? So as soon as they don't feel good, and some of my patients love it when they feel hypoglycemic, because they have bars of chocolates in their bags for when they become hypoglycemic. So if the patient pulls out something from their bag for hypoglycemia, then obviously that patients tend to having hypoglycemia quite often. Now, hypoglycemia is very difficult to define, right, for the patient. But you as a clinician need to identify the difference between symptomatic hypoglycemia and true hypoglycemia. So symptomatic hypoglycemia is where patients experience low blood sugar symptoms like hunger, dizziness, thirst, sweating, etc., when you're bringing the glucose value down from a value of, say, 15 to about 10. 10 is definitely not in the hypoglycemic range, but the patient experiences the deficit in the glucose and therefore experiences a symptomatic hypoglycemia, especially those patients who are poorly controlled. And then you get true hypoglycemia where the glucose values are truly under 4. Now, if a patient comes to you, and I have lots of patients who come to me and say, I know when my sugars are dropping and I'm getting low sugars all the time. If you're not checking your sugar, you don't know, because you could be getting symptomatic hypoglycemia and not true hypoglycemia. When I suspect a patient of getting or trying to overtreat this symptoms of hypoglycemia and the HbA1c is sitting at about 10 or 11, then I tend to rather do like a CGMS which stands for continuous glucose monitoring. And then I prove to the patient that, you know what, your sugars are actually not dropping. You are actually sitting way above range, and you need to get used to the newer values, get your body used to a newer standard, right? Instead of just eating because you think you're hypoglycemic, and defensive eating because they're afraid of getting complications, acute complications related to hypoglycemia, right? And then we need a time action profile of this basal insulin that is predictable and reproducible. In other words, when you take this basal insulin, it needs to give you the same effect every time you inject it. So with the older human insulins that we had, like the NPH insulins, patients just ate because they didn't know what's going to happen today is going to happen tomorrow and happened yesterday. They took the insulin, and sometimes sugars were fine, sometimes the sugars dropped, sometimes they were hungry middle of the night, and therefore we told patients, make sure that you eat 10 o'clock at night before going to bed. And nowadays we know, we're going into the area we were like saying, please don't eat extra, just have your breakfast, lunch, and supper. With the newer insulins that we have, there's no need to be snacking multiple times a day in order to prevent a hypoglycemic event. If your doses have been adjusted correctly, then you should be getting a predictable action every single day, as long as you're sort of doing the same sort of activity and having the same portion sizes. And if you're not feeling sick, etc., you'll get the same effect of the insulin on a daily basis. Okay, so we need time action profiles of basal insulins to be predictable, reproducible, and this will prevent too much variability in the insulin action and variability in the blood glucose values. So the patient now is on basal insulin, and the patient's fasting values are now between 4 and 7 millimoles per liter. You've up-titrated the basal dose. The patient's still on oral therapy during the day, like a metformin twice a day or a sulfonylurea once a day. Then, and the HbA1c still remains high, or when the patient is testing their blood glucose, you find that their post-meal values are still high. Then you can add a premixed insulin to the therapy. In some instances, if my patients need basal insulin, but they, for example, after supper values are higher, sometimes I tend to just add a premixed insulin before supper, just to avoid the issue of getting the one drug then onto the medical aid and then phoning a month later to change it, because it is time consuming and a little bit confusing for the patient why we keep changing the insulins. And sometimes they don't finish the entire pack of insulin that they got, and it's a total waste of a very valuable resource, right? So sometimes you can add premixed insulin from the onset, or if the patient's getting postprandial hyperglycemia, you can then switch to premixed insulin in order to get better control, right? So why do premixed insulins work well in type 2 diabetes, right? The reasons are, number one, type 2 diabetics are characterized by insulin insufficiency. However, they still have some endogenous insulin secretion. How we know this is because type 2 diabetic patients don't generally tend to get a DKA, right? DKA is diabetic ketoacidosis. Now, the only time a patient gets DKA if they are totally insulin insulin deficient, or they've missed their insulin injections in a type 1 diabetic, because type 1 diabetics don't have insulin in their system at all. So their body then cannot access glucose for energy, and it starts breaking down fat for energy in order to survive. And the breakdown product of fat measured in the bloodstream is ketones, right? So type 2 diabetic patients generally have a lower insulin action. Beta cells are failing, but they're not completely gone. So when you use a premixed insulin, you use it 12 hours apart. If you're using a full premix regime, you're taking it in the morning and in the evening, depending on the insulin, sometimes 5 minutes before meals, sometimes 30 minutes before meals. Some are about 15 minutes before meals, depending on the components of the premixed insulin, right? So when you're using that insulin, it's giving you good cover for breakfast, it's giving you good cover for supper, but lunch, sometimes the body has to depend on endogenous insulin secretion to cover you for what you may eat lunchtime. And I generally try to tell the patient that if you're using premixed insulins, then try to maybe have a smaller lunch. And then it works well for people who are still working, people who don't get a chance to have a big lunch because they're busy at work. Then premixed insulins then work very well and they are compliant to their therapy, right? So like I mentioned, they're less likely to develop DKA because they still have some endogenous insulin secretion, and they have to inject much less than when you're taking basal bolus insulin, right? So what is the dual release insulin concept? What this means is basically, as physiology states, once a person eats, you can get first phase insulin release, and thereafter you get the protracted release of the rest of the insulin as a second phase of insulin. And when you're using pre-mixed insulins, then you can get, for example, you can get the short-acting and the long-acting in one, which will then cover you for breakfast and then until supper, right? So pre-mixed or co-formulated insulins are also available, right? So those that are available are either in combinations of 30% short-acting, 70% long-acting, or 25% short-acting, 75% long-acting insulin. You do get bolus insulins with protaminated insulin in one, the premixed insulin, the analog insulins that we're using at the moment, like, for example, the Novo Mix. And then you can get bolus insulins with longer acting basal insulin analogs. So that's the newer therapies that we have. And I'm going to show you some evidence for these therapies in the coming slides, right? So we have our regular bolus insulin with the protaminated insulin, and then we've got co-formulated insulins where we've got analog longer acting basal insulins mixed with bolus insulin like aspart. Okay, so let's look at the biphasic insulin aspart, and this is basically the Novo Mix. Okay, so how is biasp, which is Novo Mix, different from the regular NPH insulin, premixed insulin that we have? Now, this is made of, as I mentioned earlier, it has a soluble part, which is 30% of the short-acting insulin, which is quickly released, and then a protaminated crystallized insulin aspart, which is 70% of the component of the premixed insulin. When it comes to premixed insulins, please make sure that you are using the pen correctly. You need to resuspend the insulin in the pen before injecting, because it is a mixed insulin. And sometimes you find that some parts of the short-acting insulin can then looks like a bit of a powder at the bottom of the pen. And then you have to reconstitute the pen nicely so that you're getting a good, nice ratio of the short and the long-acting insulin. Otherwise, you get variability of action of the premixed insulin. So sometimes you think it's a difficult to treat patient, but meanwhile, we just never told them to reconstitute the insulin, especially if they're using the older premixed insulins. Okay, so what is the data for the efficacy and safety of biasp in insulin initiation? Okay, so remember, Novo Mix has been around for many, many, many years. And as such, we have so much of data available that I thought to just summarize it. I think you're probably aware of how people inject it, etc. But these are the studies that were done, right? So they compared in the INITIATE study, they compared patients who are initiated on the mixed insulin versus the gold standard of the time, which was the U100 glargine. And what they found is patients on the mixed insulin, where patients who were initiated on the mixed insulin, baseline HbA1c dropped from 9.7% and at the end of the study to about 6.9, which was highly, highly clinically significant. Okay. There are other studies like the EuroMix study, the ACTION study, the Once Mix study, and the Easy Mix study, where they then compared the Novo Mix with different types of regimes, right? Like, so they compared the pre-mixed with a patient on basal insulin and and orals, and still the HbA1c came out tops. Okay, they compared the Novomix versus pioglitazone. That was also showed a very good result. The pre-mixed with glargine, where both patients was on both metformin and glimepiride, as in maximum oral doses, and still they seem to be an equivalent benefit with using Novomix. And looking specifically now at other studies that were done, and I find the meta-analysis is really good because it pools the results from all studies. And looking at this forest plot, you can see clearly that the Novomix seems to have a very, very beneficial effect in terms of change in HbA1c. So the closer to the line you get, as you get more to the left of the graph, you can see that's where the benefit is found, right? And so this was studies which compared basal bolus therapy to premixed insulins and all the studies that were done. And you found that a lot of the studies that had premixed crossed the line and seemed to be beneficial in terms of HbA1c reduction, right? So change in HbA1c between basal bolus and premixed group resulted in a small but non-significant difference. So although basal bolus seems to be the gold standard, it seems like premixed insulins can actually stand up to them, right? In terms of hypoglycemia, so any studies that you do in diabetes, there's three things that people look at, right? Well, four now. So the three initial things we looked at is HbA1c reduction, so can it lower glucose? Number two, does it cause hypoglycemia? And the last one is weight gain. The fourth one we're now adding on is cardiovascular disease benefit, which was just added on after the EMPA-REG study, where the SGLT2s seem to have a very surprise benefit in reducing stroke, right? So in terms of hypoglycemia and the pre-mixed insulin, what we found is that there was no statistical difference in the event rate for overall hypos in the basal bolus group versus the premixed group. So some people feel if you're using premixed insulin and you're not individually adjusting the doses, then you're going to get more hypos. But clearly, in all of these studies that were done, there wasn't a significant difference. So it's safe. In terms of change in weight, same story, no statistical difference in terms of weight change versus basal bolus group. So premixed insulin seemed to come out all right compared to the gold standard of the time. With regards to weight, HbA1c, and hypoglycemic events, right? So why do patients gain weight on insulin, right? The first thing you need to understand is that insulin is an anabolic growth hormone. It is said that patients who start insulin will gain 1 to 2 kilos per year because of the fact they're on insulin independent of their diet or exercise or whatever. So insulin itself does make you gain some weight, okay? But they're not gaining 10 kilos because of insulin. It's 1 to 2 kilos per year. So if patients, of course, if they're poorly controlled, they're losing a lot of the glucose in the urine because of poor absorption of glucose, etc., then yes, they initially do lose a lot of weight if they're not metabolically stable and they need insulin. However, in patients who are stable and they get to their stable weight again, they can't blame insulin for weight gain unless the doses haven't been titrated correctly. So if you see a patient for the first time and he's got a glucose value of like 20, but the patient has never been on a diabetic diet, he hasn't been compliant to his oral therapy, and then you start a very high dose of insulin, it will clear the glucose toxicity. But by the time the patient is discharged and they go home and they go and see their family physician and they start getting hypos, then the family physician says, hey, I'm not going to mess with this. I'm just going to stop the insulin. Go back to your oral therapy, right? Because the insulin doses weren't titrated correctly. You were too aggressive, too quick in hospital. The patient came out and wasn't given proper advice, okay? So the other thing is, if insulin doses are not titrated correctly, patients tend to get hypoglycemia. And then what do? They eat more, they have the license to have the Coke and the license to eat the chocolates and the cakes because their sugars are down. And then family members are more than willing to just serve them up a plate of something that's going to take their sugar up because they're scared the patient is going to go into a coma and die. So hypoglycemia causes increased food intake. We need to prevent hypoglycemia by titrating doses correctly and by getting patients to test their sugar to prove that it is a true hypoglycemic event, right? So titrating premixed insulin based on average glucose values can cause weight gain. So one day the patient eats very little and they get a hypo. Then the next day they eat a lot and the sugar values are higher, okay? And that can cause secondary weight gain because they're defensive eating and they're eating to feed the insulin. So weight gain is a big issue if you don't know what you're doing with insulin. Rather up titrate slowly and see how the patient responds instead of just going with a high dose thinking that, you know what, I don't think this patient's going to come back anytime soon. Let's make sure they don't get complications, right? So try to be a little cautious with titrating your insulin doses up. So that comes to then the next aspect of this presentation that I want to discuss, right? I want to discuss the newer co-formulated insulin, which has a combination of degludec, which is a long-acting analog basal insulin that has a 42-hour action, which is co-formulated with insulin aspart. Co-formulated means both these insulins work independently. So although it's injected in one pen, you don't need to resuspend the insulin and all that sort of thing. So you eradicate that error. The other thing is that because the long-acting component of this insulin has a longer duration of action, the patient doesn't have to inject the insulin at 12-hour intervals. They can inject the insulin when they eat. So the aspart, the short-acting part of the insulin, then can work on the meal, and the long-acting does its action without, it doesn't have a peak, it doesn't have variability, and the patients feel a lot better and much less hypoglycemia. So if the patient even has 3 or 4 hypoglycemic events in a month, then I tend to rather switch to the IDEC ASP, and I'm going to just give the name because sometimes people don't know what we're talking about. It's Rhizodec, right? So the Rhizodec insulin is IDEC ASP, which is degludec and insulin aspart that has been co-formulated. So in the RISE study, it was a real-world study that was designed to look at how this drug functions in patients in the general setting, right? So it wasn't a clinical trial in terms of patients are randomized and we picked the patient with the right HbA1c and we made sure that they were all matched, etc. We just took patients from the population that we had. If the doctor thought that the patient would benefit from this drug, they were switched from whatever they were on to this drug. And incidentally, the drug wasn't sponsored by the company. The drug had to be, the patient had to either fund it themselves or the medical aid had to approve the use of the drug, right? So the study was done in type 2 diabetic patients. And what they found is the primary endpoint was change in HbA1c. We were hoping that the HbA1c is less than 7. We were looking at the insulin dose and to see what total dose would the patient end up in at the end of the study. We looked at the patient's body weights, number of hypoglycemic events, and now you know this is the drill, right? So you could close your eyes and you know if it's a diabetes study, number one, we're looking at change in HbA1c, change in body weight, hypo events, and then here they added on looking at the number, the dosage of the insulin that the patient was on, right? And whether the patient had to discontinue the treatment and the reasons why they discontinued the treatment. Did they discontinue because they didn't like it, it wasn't effective, or was it because medical aid didn't approve it, they couldn't afford it, or whatever, right? So that's what they looked at in the study. What's important to note, and I've just highlighted the points because I find when you present all of these things, the main information kind of gets lost in translation. The RISE study was done in multiple countries, but nicely enough, it also included South Africa, right? It was a non-interventional study. So the doctor could decide how to uptitrate doses, whether they would like to initiate with this drug or not. And it was obviously only open to type 2 diabetics. So the data we got was from all of the countries that are mentioned there, and we included South Africa, right? And these are the results that we got. So they were, this is the type of patients that was switched then to Ryzodec, right? So the IDEC ASP. So majority of patients seem to have been on oral anti-diabetic drugs only, but their HbA1c wasn't at control. Some patients were on basal only, and then they were switched to that. Few patients were on GLP-1 receptor agonist, few on basal bolus, and some patients were on the other premixes, not this one, right? And then they were switched to the Ryzodec. And it was found that the most important reason why why doctors switch patients to this drug was to improve patients' glycemic control. However, a lot of the patients were switched because the drug has a lower risk of hypoglycemia. So therefore, the patient should then technically not gain as much weight and not have defensive eating. And for me, the big bonus of this drug is flexibility in the dosing regime, because they didn't have to keep to 12-hour actions, which the patients don't do anyway, because life happens. We know, right? You yourself could be a diabetic patient, and you try as you might to eat at a certain time. A patient comes in, or a phone call happens, or the food burns, or load shedding happens, and now you're like, I can't warm this food. I'm going to wait because it's so cold. I'll wait until the electricity comes back before I can have my meal. And then your 12-hour time period has passed. So with the Ryzodec, it can assist you in that regard, right? So looking at the various countries, there was, looking at the HbA1c reduction from the various countries, there was on average, say a 1.2 to 1.4% reduction. Saudi Arabia did very, very well in terms of like a 2% reduction in HbA1c, which is really, really good, right? But you must remember one thing, is that the drug wasn't sponsored by the company. The patient had to get it on their own, and or they had to get it approved by the medical aid. So if the medical aid approved, for example, 2 pens, right, and the patient needed to then go onto a higher dose, then you're kind of reluctant to up-titrate the dosage, because the patient's co-payments would be more, and they'll have to pay for another pen and that sort of thing. So in Saudi Arabia, they have a very nice system where patients can get whatever they want from the government hospital. They have combinations of GLP-1s, SGLT2s, plus the best insulins available. And cost is not an issue. So I think if I may say that in a country like Saudi Arabia, you can see that if we just went purely on giving patients exactly what they needed, this is the kind of HbA1c reduction you can get in the real world, should you not be bound by cost factors, etc. So in South Africa, we obviously bound by these things, you know, sometimes patients doctors maybe didn't up-titrate the dose as aggressively as they would in a clinical trial where the drug is freely available and not dependent on the patient funding it or the medical aid funding it, right? In terms of change in body weight from baseline, of course, if you look at this, the only patients who actually did like sort of gain weight is those who switch from GLP-1 receptor agonists, right? So we know GLP-1 receptor agonists help with weight loss. Some not so good as others, like you're looking at about 2 to 3 kilos with the older generation, once daily GLP-1s, and with the newer once weekly ones, we're getting brilliant weight loss. We didn't have that available at the once weekly semaglutide available at the time when the study was done. So it may have been a little bit different should that drug have been available. But basically, the premix, those that switched from other premixed insulins actually lost some weight. They didn't even gain weight. So that was a bonus in terms of switching to this insulin. And then severe hypoglycemic events. If you're looking at hypoglycemic events in the premix group, the other premix group, before starting this therapy, there was quite a significant percentage of patients who were getting hypoglycemia, right? So looking at that orange bar, whereas when they switched to the Ryzodec, patients didn't get as much basically got 0 hypoglycemic events, right? So In who would I use this drug? I would use it in a patient who's not getting glycemic control despite using various other therapies. And you can clearly see from the evidence that it works, right? I will use it in patients who's getting postprandial glucose peaks, but in those who don't want to use too many insulin injections. So you can get good control as if you're on a basal bolus therapy without getting hypoglycemia and with getting flexibility of timing and not getting that much of weight gain. So less injection burden, the regime is less complex, and you just use one pen. So older patients sometimes confuse their pens. They won't confuse their pens with this drug. So premixed insulin twice daily, how does it work? If post-meal values remain high during the day, you use obviously more insulin, right? So you need to then use the insulin twice a day. We then stop the sulfonylurea, but we continue the metformin because metformin is an insulin sensitizer. So whatever insulin your body is making or whatever insulin you're injecting from the outside, it makes it work better. So with metformin, your insulin doses tend to be a little lower. Right? So if you're having this patient that glucose is very, very high and they're on insulin, try adding metformin and try adding it at a higher dose if they're not on metformin already, and you may actually see the difference, right? And then you'll start with the premixed insulin 5 to 10 minutes before meals, before breakfast and before supper at 12-hourly intervals, and then you titrate slowly upwards until you get all your glucose values under 10 millimoles per liter postprandial, right? Remember, with the premixed insulins, the injection time must remain the same, except in the case of the IDAC ASP, where you can inject it at any time. So that's the IDAC ASP benefit, right? And you cannot adjust doses on a day-to-day basis if you're doing this premixed insulin, because it causes a lot of issues, because if you're adjusting the short-acting, you're adjusting the long-acting as well. So, and that's lasting over 12 hours. So if you want to adjust meal by meal, etc., either switch to you can switch to the IDAC ASP, or you'd rather go to a basal bolus regime, right? And please do not adjust doses according to meal sizes. Rather tell the patient to eat less if they don't want to gain weight. And then there's little scope of flexibility with the regular premixed insulin therapy that we have. So twice daily, what happens then is you're taking the injection then in the morning before breakfast, and then you're taking it again at night before supper, and you're getting a full day's cover of therapy. So stop the SU and continue the metformin. Using a basal bolus regime in certain very difficult to treat patients, basal insulin suppress hepatic glucose production between meals and overnight, and they make up about 40 to 50% of your total daily insulin needs, right? If you're using bolus insulin, this controls glucose excursions after meals, right? And this should make up about 10 to 20% of your total daily insulin requirement. However, there are some patients who have very high carbohydrate meals, and then they may actually use a greater percentage of bolus insulin pre-meals to get good control. So diet does play a big role, right? So basal insulin will target your fasting plasma glucose more than your postprandial glucose. The benefit is the basal insulin is only one, sometimes 2 injections per day. However, if the HbA1c starts going up, the patients will need a short-acting insulin to cover the glucose peaks after a meal. And this is probably the most physiologic way to go. However, it means a few injections, so at least 4 injections a day, sometimes 5, depending on the insulin that you're using, right? Pre-mixed insulin can target both fasting and postprandial. It is fewer injections. However, you can't adjust the components separately, right? So when it comes to your difficult to treat patient, look at the patient's lifestyle. See whether the drug fits into their lifestyle. Don't just force an insulin on a patient and then expect them to make it work. You are the person who can tell them, I understand the pharmacokinetics of the insulin, and this is how it works, and it's not going to work for you for the following reasons. Either you start eating breakfast, because you can't tell me you're going to eat breakfast at 11 o'clock, then you're injecting at 11, and the insulin lasts over 12 hours. so the pre-mixed insulin. So you're injecting at 11, it's working from 11 in the morning to 11 at night. Then you're having supper at, say, 6 or 7 o'clock. And then between 6 and 11, you've got an overlap of insulin. Then what happens middle of the night? The patient gets hypoglycemic. And then they don't want to use the treatment. So you need to tell them that in order for the insulin to work, you have to use it correctly. And if you as a doctor don't understand the insulin, then you can't advise the patient. So please make sure you understand the different insulins and how they work, right? So basal bolus therapy attempts to recreate physiologic insulin secretion. So you take an insulin before breakfast, before lunch, before supper. If you don't eat, you don't inject the short-acting insulin, but the long-acting basal insulin has to give you proper 24-hour cover, right? So in summary, in type 2 diabetes, you need to monitor the patient's blood glucose and HbA1c regularly so you know what's happening. If the fasting values are above 10 on average all the time, rather start a basal insulin. If the HbA1c is above 9 and they're on maximum oral therapies, please make sure you start insulin in that patient, right? To prevent complications. You should know and understand available insulin formulations. There's many out there and each of them work as long as you use them correctly, right? So make sure that when you tell a patient how to inject and when to inject, you know that it's a 12-hour action, or you must inject it before eating, and don't do it if you don't eat, you know, that sort of thing. Make sure you advise the patient so they don't get in trouble. And then you yourself understand the mode of action of the insulin and educate your patient. If you don't have time to do it yourself, please make use of the Novo educators. They know their insulins in and out, and they can sometimes do a better job than the doctors because maybe they have the time. And sometimes patients are afraid to tell us that after all these years where they were using insulin, they heard something and now they're not doing it right and the doctor's going to shout them. So one of the patients said, no, I didn't tell you because you'll get cross with me. So they did tell the educator, and the educator came to tell me that the patient mixed up the short and the long-acting insulin for like a couple of years. And I couldn't understand what was happening until the patient actually opened up to their educator, and then we discovered what the problem is and we fixed the problem up. So make use of the educators that are available. If you can, see and support your patients regularly. I know in our time-constrained world, it is difficult, but if we make better use of diabetes educators, then I think that we can help the patient to get a better outcome and not be afraid of using insulin. So in summary, we need an aggressive approach to the management of diabetes to prevent complications, but we shouldn't be aggressive to our patients. We need to be patient and we need to explain to them, take the time initially to teach them the tools of how to use insulin correctly, then you won't get problems in the future. And then you won't have a difficult to treat diabetic. It is basically a different approach to management that makes a difficult to treat diabetic an easy to treat diabetic. Thank you for your attention.
Thanks very much, Dr. Joshi, for that most insightful and informative talk. Most useful for us as GPs. So we greatly appreciate that. Just to kick off, are you able to hear me?
Yes, I am.
Yeah, I can see Dr. Bloom has said, very good talk, thank you. Comment. So, would you speak about the role of fasting in type 2 diabetes?
As in, are you talking Ramadan fasting, or are you talking about
therapeutic fasting?
Okay, like as in people that do intermittent fasting.
Yes,
that sort of thing.
Yeah.
Okay, so the intermittent fasting is giving your body a bit of a break from producing insulin all the time, right? And I recently attended a meeting, and they said that majority of patients actually don't have more than 2 hours where they're actually in a fasting state. They're actually eating and snacking all the time. I don't think that applies to us as doctors. I think we're too busy to be snacking all the time. So I found that quite surprising. But the info came from a diabetic patient. And I think that if you are on oral therapies. You can sort of get away you can get away with intermittent fasting, simply because you don't stand the risk of too much of hypoglycemia, right? However, if you are on an insulin regime, be a little bit careful about intermittent fasting. Discuss it with your doctor first before doing it, because you need to adjust your insulin doses. Initially, the values fluctuate quite a lot when patients suddenly cut calories. So you have to reduce your insulin doses to match that, right? So then you can try different regimes. Like, for example, you can, for example, take a pre-mixed insulin, say before supper. If supper is your meal and you're not eating during the day, you can then do a different type of basal insulin during the day without the short-acting component. So you can do something like that. However, you need to understand how the patient is doing this. And the other important thing is the patient needs to be consistent. They can't decide to do intermittent fasting today, tomorrow, then the next day they're feasting. So patient consistency is the key when it comes to getting simple regimes to work, right? I think a safer option for someone who is doing intermittent fasting is to use the combination therapy. If they're on basal insulin, for example, combination therapy with the GLP-1, right? So you get that the basal with the GLP-1 called Zaltify, okay? Remember, the GLP-1 only stimulates insulin secretion when you eat. Okay, and the basal insulin will then control your fasting plasma glucose values. So those who are serious about the fasting, the Zaltify would be a very, very good option for them. So that's a combination of the degludec together with the liraglutide in one injection, and you inject it once a day. So that would be a nice option, as long as the patient can afford it or the medical aid approves it. So yeah, that would be a nice option.
Thank you, Dr. Joshi. And then is it applicable or appropriate to use a premix 3 times a day, like Novomix?
Yeah, so certain patients who have maybe a very, very big lunch, high carbohydrate meals, sometimes you can use the Novomix 3 times a day, right? In certain patients, like I've seen a pediatrician who did that in a type 1 diabetic. And this type 1 diabetic unfortunately had Down syndrome, and they had a caregiver that had to give the insulin, and the caregiver used to constantly mix up what is the short and the long acting and that sort of thing. So then they gave the Novomix 3 times a day. So it has been used, but you have to make sure that the patient is testing their blood glucose. So you're not over insulinizing, so the patient doesn't get hypoglycemic episodes. Generally, if you're doing that, like the Novomix 3 times a day, the lunchtime dose or the middle dose will be a very small dose for those who are getting high post lunch values, right? But it's not something I'd advocate doing all the time. I would rather, if the patient understood well, give the Novomix before breakfast, Novomix before supper, and then give Novo Rapid lunchtime, because then I know I'm not putting the patient at risk of hypoglycemia because of stacking of the basal insulin. So I would rather do that just to be safe.
So dosing 3 times a day also poses a risk for weight gain?
If you're giving too much of insulin. So how would you know you're giving too much of insulin? Patients get recurrent hypoglycemic episodes. They're hungry all the time. They eat all the time, right? But true hypoglycemia where the value is under 4.
Okay, so from Dr. April, he said, excellent talk, diabetes made so simple in bold letters. Thank you. Colleagues, you're all muted. So if you can just use your technology to raise your hand, then I will then just unmute you. Let me
I think Dr. Duncan had a question.
I'm just going to mute everybody, and then you'll also get muted. Then I'll just unmute again. Mute. Okay. So now, Dr. Joshi, see if you can unmute. Okay, great. Okay, so everybody is able to unmute at this point in time. So just unmute and ask your question. That sounds like very happy and everything is absolutely clear and there's no question. So Dr. Joshi, once again, thanks very, very much for a comprehensive talk, and it was highly informative, and we did record it. Do you mind if we share the recording with our doctors?
I have no problem with it.
And we have a YouTube channel. Do you mind if we upload it there as well?
I don't have a problem with that.
Okay, and your slides, is it available to share, or is it
from my side, it is available. I'm not really sure what Novo's. I don't know if someone from Novo can just let me know if I'm saying the right thing. I don't have an issue from my side, actually.
Thank you. So we'll discuss it with Novo. Sorry, Michelle, come in.
Yes. Hi, hello. Not a problem whatsoever. Available with Dr. Joshi's permission. We are happy with that. Thank you very much. Dr. Joshi, I learned a few things this evening. Thank you so much. Appreciate it.
A pleasure, Michelle.
Dr. Joshi, it was really excellent. We have many talks on diabetes, and it presented new angles and gave us lots of practical points to actually implement. So thanks for sharing your knowledge and experience so freely with us. I don't see any other hands. I don't see anyone else unmuting. So then I'm
Dr.
going
Govender?
to... Yes, ma'am.
It's Taryn here, if I may.
Yes.
So yeah, from my side also, it's very practical and just a very different perspective on managing your diabetics. So I thoroughly enjoyed it myself. And like you have highlighted, just the educators, please, Dr. Govender and the ECIPA group have my contact details. And we do have a diabetic nurse educator based in our area, which the doctors have absolute free use of her education to their patients. So if they do need her, please contact me. And yeah, just thank you everyone for your time. We know that it's extremely valuable to you. So we appreciate it, and we love collaborating with ECIPA as always.
Thank you, Taryn. Thank you, Michelle. Thank you, Novo. Thank you, Dr. Joshi. And we look forward to learning from you in the future.
We'll see you soon. Thank you so much.
Okay, bye.
Good night.
So
Bye.
good night to you guys, and we'll carry on with our internal meeting. Sorry, Dr. April had a question. Sorry, Gavin.
Okay, no problem.
Yeah, Dr. April, I know that that's something that we are trying all the time. We are always in constant communication with our medical aides, and currently we have got reimbursement. It's not full, but we hope that one day we'll be able to come to all of you and say Ryzodec is reimbursed and on formulary. One day, that is my wish, so that our patients can access this amazing drug. So don't let that be the one thing that pulls you back, because we do have reimbursement at Discovery for 3 pens, and at your med scheme administered funds, anywhere from 60 to 80% reimbursement. And then, like I say, I hope in the future to come to you and say it's on formulary.
I have to second Taryn on that. Watch this space. We are working very, very hard. Trust me.
Thanks, Michelle and Taryn.
You're welcome.
Dr. Joshi, it's just, are you able to see the chat?
Yes, I am. Yes, I am.
So Dr. April's comment. Gavin, do you want to speak?
No, just to say, very informative. Sorry.
You're very faint, Gavin, and now you muted yourself. Will you unmute yourself?
Yes, I am.
Okay.
Just to say thank you very much for a fantastic talk. Absolute clarity, just laying it out to us again. And I think tomorrow I'll be looking forward to seeing patients and starting again with explaining diabetes and the different modalities of treatment, especially that of insulins. Excellent talk. Highly appreciated. Thank you very much to you and to Novo. Thank you.
Okay, so there's no further points. Dr. Shefali, you go to bed tonight with a smile on your face. You've really imparted knowledge to the benefit of your colleagues. Okay, thanks, Novo. Thanks, Michelle. Thanks, Taryn.
Thank you.
Thank you.
And